Hi, I'm Dr. Jennifer Shuford, and I'm an infectious disease specialist. This lecture is on antifungal drugs. Let's begin with an overview of fungal infections and antifungal drugs. Infectious diseases caused by fungi are called mycoses. Often these are superficial infections. An increasing number of fungal infections are deep or systemic due to chronic suppression of immune systems, and this can occur in transplant patients, cancer patients, or HIV patients. Candidiasis is the fourth leading cause of bloodstream infections. So this is just one place where we're seeing an increasing number of deep fungal infections. Fungi are different than bacteria. Fungi are eukaryotic, not prokaryotic. Fungi have rigid cell walls made primarily of chitin, a polymer of N-acetylglucosamine, and this is instead of peptidoglycan that we were seeing with the cell wall in bacteria. And antibacterials do not generally work against fungi, and antifungals do not generally work against bacteria. Fungal cell membrane contains ergosterol rather than cholesterol that we find in mammalian cells. So let's start talking about the antifungal drugs. There are antifungal treatments for cutaneous infections, and these include clotrimazole, miconazole, turconazole, butaconazole, econazole, terbinafine, griseofulvin, and nystatin. There are also antifungal treatments for systemic or subcutaneous infections. These include the polyene class, which contains amphotericin B. There's also the azoles. Within the azoles, we have the imidazole antifungals, and these include clotrimazole, ketoconazole, miconazole, econazole, bifonazole, and butaconazole. Then we have the triazole antifungals, fluconazole, itraconazole, posaconazole, voriconazole, and turconazole. And finally, we have the thiazole antifungals, and within that group is abifungin. And then we'll talk about the echinocandins. Within the echinocandins is caspofungin, micafungin, and anadulafungin. So let's actually begin by discussing drugs for subcutaneous and systemic mycotic infections. Let's begin our discussion with amphotericin B. Amphotericin B is a polyene macrolide antibiotic that's produced by Streptomyces nodosus. Amphotericin B binds to ergosterol in the plasma membrane of sensitive organisms. Amphotericin B has hydrophobic interactions with the ergosterol content of that membrane, and it's important to remember that this is not absolutely specific for ergosterol. There may be some binding to cholesterol too, which can cause some toxicities in mammalian cells. Amphotericin B then makes pores in the membrane after it binds to that the ergosterol content of the membrane. And these pores in the membrane allow electrolytes and small molecules to leak out of the membrane, and this then causes cell death. And it may help you to remember that amphotericin tears holes in the membrane by forming pores. So what's the antifungal spectrum of amphotericin B? Amphotericin B is the drug of choice for life-threatening systemic fungal infections because of its broad spectrum. It may be fungicidal or fungistatic, depending on the organism and the concentration that's achieved in the plasma. It is effective for the treatment of Candida albicans, Histoplasma capsulatum, Cryptococcus neoformans, Coccidioides immitis, Blastomyces dermatitidis, Mucor species, and many Aspergillus species, among other fungi that cause deep infections in humans. Resistance is not common to amphotericin B. When it is present, it's usually due to a decreased ergosterol content within the cell membrane. And remember that ergosterol is where the amphotericin binds, and so without that in the membrane, there's not a good binding site for amphotericin. Now, pharmacokinetics of amphotericin B. Amphotericin B is administered through slow intravenous infusion. It may be given intrathecally, and remember that means straight into the CSF. Though when it's introduced intrathecally, it is associated with neurological adverse effects. Amphotericin is insoluble in water, so sodium deoxycholate must be added to form a soluble colloid deoxycholate. So you'll often hear about the traditional form of amphotericin B being called amphotericin B deoxycholate. Other lipid formulations of amphotericin are now available, and these will cause fewer side effects. The simplest and smallest of the lipid formulations is produced by incorporating amphotericin into a single liposomal bilayer of phospholipids and cholesterol. The lipid formulations of amphotericin are very expensive and are usually reserved for patients who cannot tolerate the toxicities of amphotericin B deoxycholate. But the toxicities of amphotericin B deoxycholate are so extreme that physicians are often tempted to go straight for the lipid formulations despite their expense. Amphotericin B is distributed well throughout the body, but it does not cross the blood-brain barrier very easily. Low levels of the parent drug and its metabolites do appear in the urine over long periods of time, and they may also appear in the bile. When renal function is compromised by amphotericin B, the dose may have to be reduced. If the renal function is otherwise compromised, the amphotericin B dose may need to be reduced. To limit some of the toxicities that we see with amphotericin B, it's beneficial to sodium load the patient in patients who can tolerate it by giving saline infusions before amphotericin B infusion and after amphotericin B infusion. And this can help limit the nephrotoxicity of amphotericin B. Changing to a lipid formulation can also help preserve the renal function in patients who receive amphotericin B, and this usually improves the chances that they'll be able to complete the entire course of therapy. So let's discuss the adverse effects of amphotericin B, and there is a reason why people call it amphoterrible. It can be a terrible experience for the patients who have to have amphotericin B therapy. There's usually fevers and chills. Fevers and chills, when they occur, usually occur within 1 to 3 hours of infusion. The good thing is that they typically subside with repeated administration of the drug. The fever and chills can be reduced by pretreating with antipyretics and corticosteroids, as well as antihistamines. It may help you to remember these side effects by shake and bake. They get rigors and they get fever. If rigors do occur during treatment with amphotericin B, you can give meperidine, which does help with the shaking, the rigors that patients may have with amphotericin administration. Renal impairment is another adverse effect of amphotericin B. Amphotericin B causes a decrease in glomerular filtration rate and in renal tubular function, and this, like I mentioned, can be reduced by saline infusions before and after amphotericin B administration. This renal impairment may be reversible if amphotericin B use is promptly suspended or changed to a lipid formulation if you recognize that renal impairment is occurring during an amphotericin B therapy or course of therapy. Renal impairment is increased if other nephrotoxins are being administered simultaneously. Hypotension. Hypotension is another adverse effect of amphotericin B. Hypotension and hypokalemia can accompany amphotericin B infusion and must be promptly addressed. And you must be very careful with patients who are taking digoxin. Anemia. Amphotericin B can suppress erythropoiesis, causing a normocytic, normochromic anemia. And this may be exacerbated by other drugs. And in another lecture, we'll discuss zidovudine, or AZT, which is used for HIV therapy. And when giving medicines like AZT, which also cause bone marrow suppression, amphotericin B can have an exaggerated effect on erythropoiesis. And neurological effects. Neurological effects may occur with IV therapy, and these could include seizures, confusion, and blurred vision. But intrathecal use, when it's administered into the CSF, amphotericin B can result in some serious neurological effects, including paraplegia, urinary retention, and paresthesias. Cardiac effects may also occur with amphotericin B, and this may be associated with arrhythmias. And thrombophlebitis can be reduced with a slow infusion, the use of a central venous catheter for administration, or addition of heparin to the infusion. Now let's move on to the next antifungal drug that we'll be talking about, and that's flucytosine. Flucytosine is a synthetic fluorinated pyrimidine. It enters the cell by a cytosine-specific permease, and this is not found in humans, so it does make this treatment more specific for fungus. Flucytosine is then converted through a series of steps to 5-fluorodeoxyuridine 5' monophosphate, which is a false nucleotide which can disrupt DNA synthesis. Flucytosine is then further metabolized to a trinucleotide that is incorporated into the fungal RNA, thereby disrupting nucleic acid and protein synthesis. Let's discuss the antifungal spectrum of flucytosine. We see that flucytosine is fungistatic. It is often used in combination with amphotericin B, and one of the applications of this combination is for cryptococcus infections, including cryptococcal meningitis. It's occasionally also used in combination with itraconazole. There is some resistance that has been seen against flucytosine among these fungi. This resistance is due to a decreased enzymes involved in the conversion of flucytosine to its active metabolites, and resistance develops rapidly when flucytosine is used as a single agent. So flucytosine is not used as a single agent in treating fungal infections. It's combined with other drugs, and I was talked about most commonly it's combined with amphotericin B. Pharmacokinetics. Flucytosine is absorbed well after oral administration, and is distributed throughout the body and penetrates the CSF. Excretion of the parent drug and the metabolites occurs through glomerular filtration, and so you have to be careful in renal insufficiency. And you can imagine this is common with amphotericin B administration, and if you're using it in combination with amphotericin B, then you need to not only be aware of the renal function at the beginning of therapy, but watch the renal function and make sure that you're adjusting the dose appropriately as you go through amphotericin B therapy, because you may notice some renal insufficiency developing while on antifungal treatment and have to adjust the dose as you go. Adverse effects. There is reversible neutropenia, thrombocytopenia, and bone marrow suppression. It's associated with flucytosine. There's also reversible hepatic dysfunction that you might notice with flucytosine. GI symptoms are common, including nausea, vomiting, and diarrhea, and severe enterocolitis may occur. Flucytosine may be teratogenic, and so it should not be used during pregnancy. And as we've seen before with other drugs, adverse effects are greater when blood concentrations of the drug are very high, which can occur with renal dysfunction and with amphotericin B use. And so you just need to be aware of the renal function and adjust the dose of flucytosine accordingly. The next agent we'll be talking about is ketoconazole. Ketoconazole is the first oral azole that was available for the treatment of systemic fungal infections. For its mechanism of action, ketoconazole is primarily fungistatic. Azoles inhibit the P450 enzyme C14 alpha demethylase, which is responsible for converting linosterol to ergosterol, which is the major component of the fungal cell membrane. By decreasing the conversion of linosterol to ergosterol, it disrupts the membrane structure and the membrane function. Ketoconazole is not as specific for fungi as some later azoles are. And because it's not as specific for fungi, we see more toxicities in humans because it's actually having some interaction with human cells. Ketoconazole can disrupt the synthesis of human adrenal and gonadal steroids. It also inhibits the human cytochrome P450, and so we see more drug-drug interactions with ketoconazole than with some other agents. Ketoconazole is active against Histoplasma, Blastomyces, Candida, and Coccidioides species, but it's not active against Aspergillus. So that's an important hole in the coverage that you need to remember. Resistance to ketoconazole is becoming more prevalent with long-term therapy that is needed for some immunocompromised patients. Mutations in the C14 alpha demethylase gene decrease the affinity of ketoconazole binding, and some fungi actually have efflux pumps as well. So again, we see these same mechanisms of resistance rearing their ugly heads again and again, and here we have an altered binding site as well as an efflux pump, both contributing to the resistance to ketoconazole that's being experienced with some species of fungus. Ketoconazole is only administered by mouth. It needs an acidic environment to dissolve and absorb through the gastric mucosa. So drinking soft drinks or orange juice with administration of ketoconazole can help in the absorption of this medicine. Increased pH due to medical conditions, H2 blockers, proton pump inhibitors, all of these conditions or drugs that can increase the pH of the stomach can also inhibit absorption of ketoconazole. Penetration into tissues is limited, but it's still effective enough for deep histoplasma infections. And the ketoconazole does not enter the CSF. Metabolism in the liver is extensive, and then it is excreted primarily in the bile. Let's discuss the adverse effects of ketoconazole. GI symptoms, including nausea, vomiting, and anorexia, are most common. There are also endocrine effects that we already alluded to. Due to the disruption of the synthesis of adrenal and gonadal steroids, these endocrine effects that you might see, gynecomastia, decreased libido, impotence, or some menstrual abnormalities. About 2 to 10% of people who are on ketoconazole will have elevated transaminases, and a few will have hepatitis, so you may want to observe their liver functions while they're on ketoconazole therapy. And ketoconazole levels should be closely monitored in patients who have hepatic insufficiency. Drug interactions and contraindications. So by inhibiting cytochrome P450, ketoconazole can increase levels of cyclosporin, phenytoin, tolbutamide, and warfarin. Rifampin can also reduce levels of ketoconazole by inducing cytochrome P450. And then medications that decrease gastric acid can decrease levels of ketoconazole by inhibiting their absorption. And medications that do this include H2 blockers, proton pump inhibitors, antacids, and sucralfate. So all of these drug-drug interactions are important. Amphotericin B and ketoconazole should not be used together because ketoconazole decreases the ergosterol that's within the fungal cell membrane and thereby will decrease the effectiveness of amphotericin B since it's taking away its binding site. Ketoconazole is teratogenic in animals, and so it's contraindicated in pregnancy. All right, let's move to the next azole agent, and that's fluconazole. Fluconazole has the same mechanism of action that we saw with ketoconazole. Fluconazole can be administered IV or PO and is not dependent upon an acidic environment for absorption. It has excellent penetration into the CSF and is therefore useful for cryptococcal meningitis. It is the drug of choice for Cryptococcus neoformans, candidiasis, and coccidioidomycosis. It's also effective against most mucosal candidiasis, and this would include thrush or vulvovaginal candidiasis. Fluconazole is poorly metabolized, excreted through the kidney, and therefore must be adjusted for renal insufficiency. Fluconazole is less toxic than ketoconazole, though there are still GI symptoms, including nausea and vomiting and rashes. Rarely there's hepatitis, but there's still potential there for hepatotoxicity. And fluconazole may also be teratogenic, like other azoles, so they should not be administered during pregnancy. Fluconazole does not have the endocrine side effects that ketoconazole has, but it may still inhibit drug metabolism that relies on cytochrome P450 enzymes, and so you still need to look for drug-drug interactions when you're administering fluconazole. All right, now let's move to the next azole agent, itraconazole. Itraconazole is a synthetic triazole with a broad spectrum. Itraconazole is orally absorbed, which again is dependent on an acidic environment. And food increases absorption in some formulations. Itraconazole is extremely protein bound and distributes well to most tissues, but does not penetrate the blood-brain barrier and get into the CSF, unlike what we saw with fluconazole. Itraconazole is extensively metabolized by the liver, but it does not interfere with androgen synthesis. Its major metabolite is also active, and it does not need to be adjusted for renal function. Itraconazole is the drug of choice for blastomycosis, sporotrichosis, paracoccidioidomycosis, and histoplasmosis. Adverse effects related to itraconazole include GI symptoms and rashes, which is exactly what we've seen with the other azole agents, as well as hypokalemia, hypertension, edema, and headache. Again, itraconazole is contraindicated in pregnancy because of the potential for teratogenicity. It does interact with the cytochrome P450 system, and it inhibits metabolism of some drugs such as statins, oral anticoagulants, and quinidine. Drugs that induce the P450 system, like rifampin, will decrease levels of itraconazole, so you need to watch out for those drug-drug interactions. The next azole agent that we'll be talking about for the treatment of deep or subcutaneous fungal infections is voriconazole. Voriconazole is a broad-spectrum azole that is also available as an oral or intravenous formulation. Voriconazole is absorbed well and distributed widely and does penetrate the blood-brain barrier and get into the CSF. It is the treatment of choice for invasive aspergillosis, and it's also approved for serious infections with Scedosporium and Fusarium species. It too is metabolized through the P450 system and has many drug-drug interactions. Side effects of voriconazole include transient visual side effects that occur within about 30 minutes of administration. These side effects, the visual side effects, can be very disturbing to patients. They can see wavy lines, just blurred vision. Their vision can be very distorted, and so it's really important to warn them about this before you administer that drug. Other side effects associated with voriconazole are similar to what we were seeing with the other azole agents. Now we'll talk about another azole, posaconazole. Posaconazole is a newer azole that was approved in 2006 to prevent Candida and Aspergillus species in severely immunocompromised patients and for treatment of oropharyngeal candidiasis. It's one of 2 drugs with activity against mucor species and other zygomycetes. Mucor and other zygomycetes are just dreaded fungal infections that can progress rapidly and kill people. And so to have activity against these species is a really wonderful development amongst antifungals. It is well tolerated. The most likely side effects include GI symptoms and headaches. It may increase the aminotransferases, and so it's important to follow the LFTs, especially on long-term therapy. And patients receiving cyclosporin or tacrolimus post-transplant are at risk for hemolytic uremic syndrome, thrombotic thrombocytopenic purpura or TTP, and pulmonary embolism. And since this drug is used specifically for severely immunocompromised patients, transplant patients fall into that group. And so you may very well see these adverse effects as a result. So it's important to be aware of the potential for HUS, TTP, and pulmonary embolism. Posaconazole does inhibit the cytochrome P450, thereby increasing concentrations of cyclosporin, tacrolimus, and sirolimus, as well as other medications. And again, since these medicines are found in transplant patients who may very well be using this drug, it's important to know about these interactions. Posaconazole is contraindicated with ergot alkaloids, pimozide, and quinidine. Dosing is once daily for oropharyngeal candidiasis, but it's 3 times daily for prophylaxis of aspergillosis or candidiasis, so you can see how that might become burdensome. All right, now we're going to move on to the next class of antifungals, and these are the echinocandins. There's caspofungin, micafungin, and anidulafungin. Caspofungin was the first approved echinocandin in the United States. Echinocandins interfere with fungal cell wall synthesis by inhibiting the synthesis of beta-1,2-D-glucan, which eventually leads to lysis and cell death. It's not available for oral administration, it's only administered IV. The spectrum is limited to Aspergillus and Candida. It's slowly metabolized by hydrolysis and N-acetylation, and it's eliminated equally through both the urine and the feces. Adverse effects for caspofungin include rash, fever, nausea, and phlebitis. And flushing may also occur during caspofungin administration, and this flushing probably results from histamine release. Do you remember another antimicrobial that we've talked about that results in flushing from a histamine release process? That's vancomycin. Vancomycin has the red man syndrome, and caspofungin can cause a similar picture with flushing that results from histamine release. Caspofungin should not be co-administered with cyclosporin. Now let's talk about anidulafungin and micafungin. These are newer members of the echinocandin class, and they too are only available through IV. They are not substrates for cytochrome P450 enzymes, and so there are no associated drug-drug interactions.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together, we'll go through the quick review in the study guide.
What are the adverse effects associated with amphotericin B? Fever, chills, hypotension, electrolyte disturbances, renal failure, hepatotoxicity, anemia. Are you really this stupid, or are you just lazy? Maybe I'm the butt of some horrible practical joke. Where's Ashton Kutcher? Come on out.
Hi, I'm Dr. Chris Lewis. It's time for your quick review number 1. Let's get started. List some of the therapeutic uses for amphotericin B. Now, remember, our amphotericin B is reserved for those serious systemic infections. We're not just going to throw it willy-nilly at mild skin infections. So you want to use this sparingly because it does have a lot of side effects. But what does it treat? Well, it'll treat Candida albicans, Histoplasma capsulatum, Cryptococcus neoformans, Coccidioides immitis, Blastomyces dermatitis, Mucor species, and Aspergillus species. Next, what are the side effects of amphotericin B? Remember, this is amphoterrible, so it's pretty tough to tolerate. So you can get fever and chills, renal impairment, hypotension, hypokalemia, anemia, neurological deficits, cardiac problems, including arrhythmias, and thrombophlebitis. How can you prevent the fever and chills associated with amphotericin treatment? Well, you can pre-treat with medications. You can use things like antipyretics, things like acetaminophen or NSAIDs. You can also use corticosteroids, and then you can also use antihistamines. Next, what neurological complications can occur when administering amphotericin B intrathecally? So you're putting it into the CSF. What can happen? Well, you can get paraplegia, you can get urinary retention, and you can get paresthesias. What reversible adverse effects are seen with administration of flucytosine? Well, you're going to see a lot of blood problems with this. So you're going to see neutropenia, thrombocytopenia, bone marrow suppression. Then you can also get hepatic dysfunction. Next, ketoconazole is not active against what organisms? So this is very important. There's a pretty big hole in ketoconazole's coverage, and it's Aspergillus. So if you have an Aspergillus species infection, you don't want to use ketoconazole. What are the advantages of using fluconazole over ketoconazole? Well, fluconazole is less toxic and also very important, it has no endocrine side effects. So remember that ketoconazole will have a lot of androgenic problems. You can get problems like impotence, gynecomastia, and problems like that. So that's one of the main reasons why we don't use a lot of the ketoconazole anymore, and we like to switch to fluconazole. It's very easily tolerated and very commonly used. What adverse effect is very important to warn patients about before starting them on voriconazole? So voriconazole, great medication, but it can potentially give you transient visual side effects. So it can be very disturbing for patients. They're taking a medication, all of a sudden their vision starts changing. So you want to make sure they know that ahead of time before taking the medication. Next. What medication can be given to a patient on amphotericin B who begins to experience rigors? So maybe you did pre-treat this patient, maybe you didn't pre-treat them with the things we talked about before, but now they're experiencing rigors or they're really getting a bad shaking chills. Well, you can use meperidine to help decrease that experience. What azole drug does not penetrate the CSF? Well, this is again ketoconazole. If you have a bad CSF infection, you don't want to use ketoconazole. What was the species that we just talked about that it didn't cover also? Aspergillus. What is the main benefit of using liposomal amphotericin B? So there's several different types of amphotericin B. Some are more expensive than others, but the liposomal amphotericin B will have decreased nephrotoxicity. So it's not going to affect your kidneys quite as much as the other types of amphotericin B, and that's one of its primary uses. Well, that's going to conclude our quick review number 1. Let's get back to your main lecturer.
Okay, now we're going to move from talking about drugs that treat deep or subcutaneous fungal infections to drugs that treat cutaneous mycotic infections. Fungi that cause cutaneous mycotic infections are frequently called dermatophytes. Common dermatomycoses are sometimes called ringworm, which is a misnomer because it's not caused by a worm, it's caused by fungus. Dermatophytes include Microsporum species, Epidermophyton species, and Trichophyton species. And infections with these species of fungus can lead to tinea pedis, tinea crurus, tinea corpora, and tinea capitis. So let's begin with terbinafine and discuss its mechanism of action. Terbinafine inhibits fungal squalene epoxidase. It results in a decrease in ergosterol. It also results in an increase in the squalene concentration, which is then toxic to the fungus. Terbinafine is primarily fungicidal, and either of the mechanisms that we just discussed can cause cell death. For its antifungal spectrum, terbinafene's activity is limited to Candida albicans and other dermatophytes. It's especially useful for the treatment of onychomycosis, which is a fungal infection of the nails. The length of therapy is typically prolonged, about 3 months, but it's usually not as long as what you would expect with griseofulvin therapy. Pharmacokinetics. Terbinafene is orally absorbed, but probably only about 40% bioavailable because of the first pass effect. It is extensively protein bound, about 99%. It's deposited in skin, nails, and fat, which is exactly where we want it for dermatomycosis. It's also, though, in breast milk, so it's contraindicated for lactating women. It is extensively metabolized prior to urinary excretion, so either renal or hepatic insufficiency may require a dose adjustment. And its adverse effects. Most commonly, the adverse effects are just limited to the gastrointestinal symptoms such as nausea, dyspepsia, and diarrhea. It may cause rashes or headaches. There may also be some taste and visual disturbances and transient rises in liver enzymes from terbinafene administration. The adverse effects that people do experience from it, though, almost always resolve upon cessation of the therapy. It rarely causes hepatotoxicity and neutropenia, but it is possible. And rifampin reduces serum concentrations of terbinafene, while cimetidine increases it. So again, with the cytochrome P450 interaction, you just have to really watch for those drug-drug interactions. All right, griseofulvin. Griseofulvin has largely been replaced by terbinafene. Griseofulvin is a fungistatic agent, and it accumulates in newly synthesized keratin-containing tissues. It disrupts the mitotic spindle there and inhibits fungal mitosis. The duration of therapy for griseofulvin depends on the rate of formation of new skin and nails, but therapy typically lasts between 6 and 12 months. It'll last a little bit longer for toenails versus fingernails. It really depends on how quickly your body is forming the new skin or nails. Oral absorption is improved with high-fat meals. And I have run into that question on tests before, so you may want to remember that, griseofulvin and high-fat meals. Griseofulvin induces cytochrome P450, increasing the metabolism of some other drugs, including oral anticoagulants. Adverse effects include GI symptoms and headaches. Rarely, confusion can be caused by griseofulvin. It does seem to have teratogenic effects and carcinogenic effects in lab animals, so it shouldn't be used during pregnancy. Griseofulvin may also exacerbate intermittent porphyria, and so it shouldn't be used in those patients. And griseofulvin should not be used with alcohol. So if someone's on griseofulvin therapy, they should abstain from alcohol during the duration of their therapy because it can increase the sensitivity to alcohol. Okay, so now we've talked about terbinafene and griseofulvin. Now let's move on to the next agent for cutaneous fungal infections, and that's nystatin. Nystatin is a polyene antifungal, much like amphotericin B. Its structure, chemistry, mechanism of action, resistance mechanisms all resemble those of amphotericin B. Because of toxicities, which we also see with amphotericin B, nystatin is only used topically to treat candida infections like diaper rash or vulvovaginal candidiasis. But it may also be used orally for a swish and swallow or swish and spit treatment of oral candidiasis. There is negligible absorption from the GI tract, and it's excreted in the feces. Nystatin swish and swallow can be very helpful for people with oral candidiasis because they not only have it within their mouth but also going down their esophagus, and so by swishing it and swallowing it, you actually get good treatment of all of those surfaces that might have the candidiasis, whatever mucosal membranes are involved with that infection. There's almost no adverse effects from nystatin because it's used topically, but it still may cause some nausea and vomiting, especially if it's the swish and swallow. All right, now we're going to talk about some azoles that are used for treatment of cutaneous fungal infections. These include miconazole, clotrimazole, butaconazole, and turconazole. Again, these are used topically. They're rarely used parenterally because of the potential for toxicities. The mechanism of action and the spectrum of activity is similar to what we saw with ketoconazole. And topical use can be associated with contact dermatitis, vulvar irritation, and edema. Miconazole can raise the concentration of oral anticoagulants in the blood even when it's used topically. And so if you have a patient who is predisposed to bleeding disorders or who is on anticoagulant therapy and begins to have bleeding complications, it's important to ask them everything that they're taking, even if it's a topical agent, because miconazole can predispose to those bleeding complications. There's another just important point about miconazole treatment is that there's no significant difference in clinical outcomes resulting from nystatin therapy versus azole therapy of vulvovaginal candidiasis. They seem to be equally effective.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
And once again, it's time to play Name That Drug. What drug is known to cause the following side effects? Itching, burning skin. Difficulty breathing. Numb, tingling sensation in hands. Nausea. One more hint. Gynecomastia. Time's up! These side effects were caused by ketoconazole. Ketoconazole may inhibit synthesis of testosterone and adrenal steroids, resulting in gynecomastia and oligospermia in men and menstrual irregularities in women.
All right, we're back. It's time for quick review number 2. Let's get started. Match the following dermatophytic infections with their corresponding location. So remember, with all these infections, they're in different locations, but it's basically the same organism. So you're having the same types of dermaphytes, but they're just in different areas. So tinea pedis is in the feet. It's also known as athlete's foot. Tinea cruis is in the groin, and we call that jock itch. Tinea corporis is on the body, and we call that ringworm, though it has nothing to do with worms. And then tinea capitis is on the head. Next, which medication reduces serum concentrations of terbinafine, and which medication increases the serum concentrations? So rifampin will reduce serum concentrations, and then cimetidine will increase serum concentrations. How do you improve oral absorption of griseofulvin? Remember, we're going to use this for our trickier dermatophytic infection, especially in the scalp or in the nails. Well, you're going to take this with a high-fat meal, and that's how you get a greater absorption of that oral griseofulvin. Next, topical use of azoles can cause what adverse effects? So you can get dermatitis, you can get vulvar irritation, and you can get edema. Next, why is nystatin restricted to topical treatment of Candida infections? Well, nystatin is pretty similar to amphotericin B, so you can kind of remember those two in combination as being very difficult to tolerate, and that's due to their toxicity. So nystatin is even more toxic, so that's why we use this mainly just as a topical treatment. Now, don't be fooled, because one of the things we use nystatin for is for oral candidiasis. So we have people do a swish and swallow. So they're actually swallowing nystatin, but it's a relatively low dose, and it's not meant to be absorbed in the GI tract. It's meant to just coat the inside tract. So it's trying to treat that esophageal candidal infection. And then it doesn't really get absorbed enough to cause any of the toxicity. So even though we are swallowing that nystatin, we're really not absorbing it. If a patient has aspergillosis, which azole would you want to avoid? Remember, we talked about this at our last quick review. You want to stay away from ketoconazole because it's ineffective against aspergillus. What is the usual treatment course of terbinafine and griseofulvin for onychomycosis? So remember, with our onychomycosis, it's really difficult to get that fungus out of the nails. And you can try using topical creams and ointments and all that type of stuff. It really doesn't work. And even you have to warn your patients about the length of treatment of these medications because if you tell them, well, let's just start this, they have the impression, well, gosh, in a couple weeks this will be gone and I'll be done. Well, the truth is for terbinafine, it takes about 3 months. And that's more of a shorter duration than our griseofulvin because you have to use the griseofulvin for over 6 months. So really let your patients know this is a long haul. I do have patients who fail treatment where they have to take it longer than that amount of time, and sometimes they have to take it for a second round if it starts to come back. So just be prepared to explain to your patient this is a hard infection to treat. What antifungals are commonly used to treat vulvovaginal candidiasis? This is a very, very common problem. Women will come in with yeast infections, and a lot of them have tried using over-the-counter medications on their own. So they can get a lot of these nice insert-type medications over the counter, but oftentimes they'll still come to you for first line. So oftentimes we'll use topical clotrimazole or nystatin. And then very commonly, women are asking for the single oral dose of fluconazole. So you'll have a lot of women coming in, it's like, I just want the one-time pill, that's so much easier. And it is, so we end up prescribing that pretty often. Also, when you're treating your female patients with antibiotics, some are very sensitive to having super infections with candidal infections after taking broad-spectrum antibiotics, and they'll ask for that fluconazole as just a preventative medication, and that's okay too. But just be aware that there are over-the-counter versions that you can point your patients to if they want to try to get that as well. Next, what antifungals are commonly used to treat thrush in an infant? So you'll see this quite commonly. You know, infants, their immune system is not as robust as a full-grown adult, so they will get candidal infections in the mouth. First, we usually grab for nystatin oral suspensions. You squirt a couple cc's in each cheek, and you have the parents either move it around with their finger, or some people like to use swabs or that sort of thing. And if that doesn't work, you can use fluconazole as well. What is the antifungal of choice for tinea capitis? So we talked about this before. You're going to use griseofulvin or terbinafine, and that terbinafine is a shorter course for your patients with tinea capitis. And that's going to conclude our quick review number 2. Now's a good time to pause the video and complete the in-session quiz. Then restart the video and we'll go through the quiz together. All right, you've made it to the end of session quiz. Let's get started. Which antifungal fits the following statement? So we got the characteristics on one side and the antifungal drug on the other. So characteristic, interferes with microtubule formation. That's going to be griseofulvin. Swish and swallow for oral candidiasis or thrush. We're generally going to use a nystatin. Cell wall synthesis inhibitor used in invasive aspergillosis. That's going to be caspofungin. Binds ergosterol and makes membrane pores. That's going to be amphotericin B and nystatin. Inhibits ergosterol synthesis. That's going to be your azoles, but you can also use terbinafine. Most common treatment for onychomycosis. That's terbinafine and griseofulvin. A side effect of arrhythmias and nephrotoxicity. Remember, that's amphotericin B. It's amphoterrible. Deposits in keratin-containing tissues. That's your griseofulvin. That's why it's so good for onychomycosis infections. Inhibits hormone synthesis and cytochrome P450. And that you think about azoles, especially ketoconazole. Side effect of liver dysfunction. Think of azoles and griseofulvin. Side effect of that it's teratogenic and carcinogenic. That's griseofulvin. Converted to fluorouracil and inhibits DNA synthesis. That is flucytosine. Drug of choice for sporotrichosis, and that's itraconazole. Which antifungal can be used intrathecally for fungal meningitis? Well, if you think of meningitis, that's a pretty serious infection, so what are we going to grab for our really serious systemic infections? Amphotericin B. What is the clinical use of griseofulvin? Well, you can use it for superficial fungal infections, and it can be given orally. Usually you're going to think about tinea capitis or onychomycosis infections. What could explain the increased incidence in fungal infections in the recent years? Well, this is a bit of a long answer, but there's a greater number of people on chronic immunosuppressant therapy. So think of your patients who have rheumatologic disorders. They're on steroids or other immune suppressant medication. Also, patients who have immunodeficiency disorders, so patients with HIV or AIDS. And then also, we don't think about this in the same category quite so much, but think of our diabetic population. They have a much higher incidence of candidal infections. And in some cases, if you have a patient with a new onset candidal infection, you probably need to screen them for diabetes to be on the safe side, especially if they have some of the other worrisome risk factors, being obese or have a family history of diabetes. So think of all those things when you're thinking about, well, why does a patient have a fungal infection? Think of immunosuppression, think of diabetes, and that sort of thing. Match the mechanism of action to the correct antifungal drug. So ketoconazole will block demethylation of linosterol to ergosterol. Flucytosine enters the cell through non-mammalian permease and acts as a false nucleotide. And caspofungin will interfere with the synthesis of the fungal cell wall. Next, what is the most appropriate therapeutic agent for the following conditions? So let's go through these. 64-year-old female with systemic life-threatening Candida albicans infections. Remember, life-threatening systemic amphotericin B. 50-year-old HIV-positive male with systemic cryptococcus infection. You want to use amphotericin B plus flucytosine. 47-year-old who just returned from a 6-month Australian backpacking adventure and now has histoplasmosis infection. You want to think of itraconazole, but you can also use fluconazole or amphotericin B. 32-year-old female with onychomycosis infection. Usually you're going to grab for terbinafine or griseofulvin. Young child with oral thrush Candida albicans infection in the mouth. Think of nystatin. Severe disseminated infection with coccidioides immitis. And you're going to use itraconazole, fluconazole, or amphotericin B. What are the side effects of amphotericin B? So real important to remember this. We've kind of hammered this into your brain. Amphotericin B is amphoterrible. Fever, chills, renal impairment, hypotension, hypokalemia, anemia, neurological problems, cardiac problems including arrhythmias, and thrombophlebitis. Next, list the agents generally employed for cutaneous mycotic infections. So think of terbinafine, think of griseofulvin, nystatin, and miconazole. A 35-year-old male is taking an oral antifungal for systemic mycoses and now complains of decreased libido and impotence. Which antifungal is he probably taking? Well, that's going to be ketoconazole. Remember, this is going to block androgen and adrenal steroid synthesis. So you're going to get those androgenic problems of the impotence, sometimes gynecomastia even. A patient has been treating his athlete's foot infection with over-the-counter medications without success and now comes to the clinic for treatment. What medication is most likely to be prescribed in this scenario? So if he's using over-the-counter medications, he's probably already used clotrimazole, maybe nystatin. There's a lot of these medications are over-the-counter, so he has either a resistant infection or something else going on. So probably the first thing you need to do is make sure it's really a fungal infection. You know, some people come in thinking they have a fungal infection when maybe they have cellulitis, maybe they have something else going on, something bacterial. So be sure to really confirm that they actually have a fungal infection. And then you're going to have to go to something more systemic. You might want to use terbinafine for these patients who have real resistant infections that are not working or not being cleared by topical medications. What regimen of pre-medication can be used to help prevent some of the side effects of amphotericin B? So we've talked about this before. You can use a saline infusion before and after administration, antipyretics like NSAIDs, antihistamines, and corticosteroids to help prevent some of those really rough side effects of the amphotericin B. All right, well, that's going to conclude your in-session quiz. I hope you learned something, and good luck studying.